Can't intubate, can't oxygenate, declare CICO. Call for help now. Bring the difficult airway cart. Prepare emergency front of neck access.
The induction was uneventful. The first laryngoscopy revealed a grade 4 view. A second attempt failed. You insert a supraglottic airway, but it refuses to ventilate. Watch this monitor. Within seconds, the capnography waveform flattens out, and the oxygen saturation plummets from 98% down to 82%. This exact physiological state is known as can't intubate, can't oxygenate, or CICO. Every anesthesia professional must know exactly how to manage it. At this precise moment, your mental priority must change. Securing the anatomical airway is no longer the goal. Restoring oxygen to the patient's cells is the only priority. Patient mortality in a CICO event rarely stems from a lack of technical intubation skills. It happens because of a catastrophic delay in transitioning our mental models. We freeze, we hesitate. To prevent this, we are going to map the pathophysiology of rapid desaturation, deconstruct the Difficult Airway Society escalation protocol, and detail the strict mechanics of the surgical rescue. Experienced elite anesthesiologists consistently fall into a fatal trap. Under immense pressure, the brain rationalizes taking just one more look with a different blade. In a CICO event, clinical ego and standard anatomical objectives must surrender instantly to the raw physiological demand for cellular oxygenation. Look at the immediate, hidden consequences of a failed, forceful laryngoscopy. The blade applies high pressure to the delicate tissues of the glottis, causing immediate microtrauma. Subsequent attempts compound this trauma rapidly. A cascade of severe tissue edema and bleeding begins, completely obscuring the glottic opening and turning a narrow passage into a solid blockage. This is where cognitive fixation becomes the primary pathology in the operating theater. In a high-stress environment, a practitioner's brain locks onto the initial task of placing the endotracheal tube. This singular focus blinds them to the escalating physical damage they are causing with their own hands. The physical reality is a rapidly swelling closed airway. Yet the clinician clings to a false hope that the next blade or a slightly different angle will miraculously succeed. Every single additional attempt at laryngoscopy makes the rescue harder. You are swelling the tissue and narrowing the passage, physically turning a difficult airway into an impossible one. This graph illustrates the oxygen-hemoglobin dissociation curve, mapped against time during an apneic event. It shows us exactly how physiological data is misinterpreted during a crisis. Notice the plateau phase at the top. The SpO2 readings stay artificially high and stable for precious minutes, even after ventilation has completely failed. Then you hit the steep drop-off point, and saturation plunges. Waiting for the oxygen saturation to drop to 80% or 70% before changing strategy guarantees the patient is in an irreversible physiological freefall. Your true early warning signs of failure are mechanical and ventilatory. A flatlining ET CO2 trace on your capnometer, and suddenly poor bag mask compliance in your hand. You must contrast these early leading indicators against the lagging indicator of falling SpO2. This reframes your actual window of opportunity to intervene. If you wait for the oxygen saturation alarm to sound before abandoning intubation, you have lost the critical window to prevent hypoxic brain injury. Here is the Difficult Airway Society CICO algorithm. It functions as a rigid mechanical tool designed specifically to force clinical pivots. When Plan A, intubation, fails, your immediate priority is to shift to Plan B and C. You optimize bag mask ventilation and place a supraglottic airway. You step away from the endotracheal tube. The guidelines build in a strict algorithmic limitation. You are permitted an absolute maximum of 3, ideally 2, intubation attempts before you must move on. If both the supraglottic airway and bag mask ventilation fail to produce a capnography trace, you cross the point of no return. You progress immediately to Plan D. A crucial human factor intervention is required at this node. The lead clinician must loudly and clearly declare, "This is a CICO situation." This specific verbal declaration instantly breaks the surgical team's groupthink. It recruits immediate help and entirely resets the room's operational priorities. Simultaneously, the team executes final non-surgical optimizations. You adjust the patient's neck position, ensure neuromuscular blockade is complete, and call for the specific surgical airway tools. The DAS algorithm operates as a psychological circuit breaker. It is designed to save the highly trained clinician from their own task fixation. This brings us to the absolute final pathway of airway management: emergency front of neck access, or eFONA. Under immense pressure, you use the laryngeal handshake technique. You stabilize the larynx with your non-dominant hand and identify the cricothyroid membrane between the thyroid and cricoid cartilages. You make a definitive transverse stab incision directly through the cricothyroid membrane using a number 10 scalpel. Next, you rotate the scalpel blade exactly 90 degrees. Its sharp edge points toward the patient's feet, holding the stoma space open. You slide the coude tip of a bougie caudally alongside the blade into the trachea. You remove the scalpel and railroad a lubricated size 6.0 endotracheal tube over the bougie to secure the airway. This table highlights why modern guidelines definitively favor the scalpel technique over older cannula approaches. The scalpel offers a high first-pass success rate and establishes a definitive airway, avoiding the high failure rates and barotrauma risks of high-pressure cannula ventilation. The primary psychological barrier to executing this procedure is paralyzing fear. Clinicians worry about causing severe bleeding or making a critical anatomical error with the blade. In a confirmed CICO event, the risk of hypoxic brain death outweighs any risk from a surgical complication. Make the cut. The core survival loop of a CICO crisis requires 3 distinct actions: early recognition via capnography, immediate verbal declaration to the room, and completely abandoning intubation for front of neck access. If I am in this situation, I remember that the most effective airway rescue does not happen during the crisis. It happens before induction through meticulous preparation for failure. Capnography is your best friend and the ultimate truth teller in the operating theater. Ignoring its absence is the fastest route to a catastrophic outcome. The patient's collapsing airway does not care about your clinical hierarchy, your years of experience, or your past successes. It only demands oxygen. The speed of your cognitive transition, the exact moment you abandon your ego and your intubation attempts to focus solely on oxygenation, determines whether the patient survives. If you found this breakdown valuable, subscribe to the Surgery and Anesthesia channel for more rigorous, evidence-based clinical deep dives. Share this with your colleagues, anesthesia residents, and OT staff. Please leave your own difficult airway clinical experiences and questions in the comments below so we can continue learning together. True mastery in anesthesia is not just the technical skill to secure an airway. It's the profound wisdom to know exactly when to stop trying.